Hello, this is Ileana Pina from Wayne State University and Detroit Medical Center in Detroit, Michigan in the United States. And this is my blog. I borrowed Dr. Pietzke from Berlin. He's from Charité Hospital, which is probably one of the most important institutions in Germany that does a lot of procedures, do a lot of devices, and are really leaders in the front. And Dr. Pietzke is the chair of cardiology. So thank you for taking the time. I know it's been incredibly busy. And we had the presentation of Paragon. And we have been very eagerly waiting for Paragon. So do you want to tell us a little bit and tell the audience about what is the total structure of the study? What was its purpose?
Yeah. So thank you, Eliana, for the opportunity to discuss with you. So Paragon HF is a state-of-the-art phase 3 outcome trial in heart failure with preserved ejection fraction. And it is important to understand that heart failure with preserved ejection fraction is a common disease, and we estimate that nowadays almost half of our patients that are admitted for heart failure to our hospitals do have heart failure with preserved ejection fraction.
In my place, it's 40% of all admissions are
Isn't it? So
HFpEF.
it's
Yes,
high. It's a high proportion, and these patients are in a desperate situation because their signs and symptoms of heart failure are as severe as in heart failure with reduced ejection fraction.
And they're very limited, very limited.
And they are very limited, and we have no good therapeutic strategies for them. So we do not have any medication or therapy that would improve their outcomes. And the recommendations are risk factor control and diuretics for
and getting blood pressure control. That's all in the guidelines.
Exactly. Yeah. That's on the guideline, but nothing specific. So Paragon HF reached out to address this using sacubitril valsartan and tested in over 4,400 patients prospectively whether sacubitril valsartan would be superior to the comparator valsartan alone in reducing cardiovascular death and repeat heart failure hospitalizations. And we waited eagerly for the results, which were presented yesterday here in Paris in the hotline session, and Scott Solomon from Boston presented these data. So the key result was that there was a marginal 13% reduction in the primary outcome.
And the primary outcome was a combination
of cardiovascular death and repeat heart failure hospitalization. Okay. So it was first and
it's time to first event.
It is a little bit beyond time to first event. It is first heart failure hospitalization, but then adding also other following heart failure hospitalizations.
Okay, so it's more the totality,
the totality.
The POPOC.
Exactly, yeah. So, and that 13% reduction just missed the level of significance of 0.05, and so this is the top line result here. We have a clear signal of efficacy which just missed, the level of significance, and I learned from the biostatistician they would have needed just 7 more events.
Oh my goodness.
But that's how it is.
So why was the comparison done to valsartan?
Yeah.
Just tell the audience. I understand why.
Yeah. So that's a very important question, because of course valsartan per se may already have some effect and benefit. Over 70% of the patients that had been randomized into Paragon HF were before randomization either on an ACE inhibitor or on ARB, probably for hypertension.
Right.
And I think the investigators thought it might hamper recruitment into the trial if you say you have to get rid of this antihypertensive therapy and then randomize against the placebo.
So it's probably done for ease of enrollment.
Absolutely.
Because it was a hard trial to enroll.
Yeah.
I had it in the United States, and most of my ladies were overweight, and I couldn't put them in because there was a BMI cutoff.
Yeah.
And I
Yeah.
had some of them on a diet so that I
Oh
could,
God, to
so
get
that
the
I could get them
BMI
into
down,
the study. But
which might help anyway
it
already
was very
for, yeah.
difficult. Tell us about the mortality endpoint. I know it would be an exploratory endpoint, the mortality.
So,
What was the annual mortality?
so the annual event rate was in the range of 13 per 100 patient years, 13.6 if I recall that number correctly. And that was the combination of death and heart failure hospitalizations. And there was the majority of the effect was derived from reductions in heart failure hospitalizations, and there was very little effect on mortality, cardiovascular death, and overall mortality. There were interesting additional observations. First, the intervention was safe.
Yes.
So
We
it
know it's
lowers
safe.
blood pressure. So hypotension was the most prominent adverse effect, if you want to say
But
so.
we know that from the drugs. I mean,
Exactly,
that's
we
not
know
unusual.
that from Paradigm.
Yeah.
But as in Paradigm, in HFrEF, it prevented progression of renal failure. And that was a significant a difference. And it had other important, there were other important and interesting observations from Paragon HF. And in the subgroup analysis, and that struck me most, was we see the very clear-cut information on a certain heterogeneity of the effects of the drug in subgroups of patients. And there were two subgroups which did attract our attention and that we discussed already extensively over the last few days. Women benefited more than men, and this interaction was highly significant.
Very interesting.
We don't understand why, but that is a very clear-cut observation. And patients with an ejection fraction, left ventricular ejection fraction below the median, so 57 and lower.
Do you think that's MREF? Do you
It's,
think that's the MREF group that the
yeah,
SC
it
has?
goes into that direction.
Yeah.
I mean, remember the cutoff to include patients was an ejection fraction 45 and higher.
Right.
45, so not below 45. 45 and higher. The median was 57. Those between 57 and 45, they had a clear benefit, and those above 57, the benefit faded away.
Yeah.
So obviously there is heterogeneity in patients with HFpEF, and those with a
Which we've been talking about for years,
Absolutely.
that they're not all the same.
Absolutely,
Yeah.
they are definitely not
But
all
you know,
the
if
same.
you go back and look at CHARM, for example, I don't know that in CHARM the women were analyzed separately, but there were a lot of women in CHARM preserved. And the populations are very similar. I went back and I looked,
Yeah.
and the populations are very, very similar. And if you go back into AHEFT, the women who were mostly hypertensive had a remarkable benefit from that combination early in the trial.
Yeah.
So I'm wondering if, you know, since I'm interested in the women in heart failure, is it that the hypertensive women just respond better, quicker?
Yeah.
And when they
Yeah.
present with this, it's all blood pressure, it may be all blood pressure
Yeah.
related.
Yeah.
We may be looking at hypertensive heart disease in
Yeah.
women.
Yeah.
Just fascinating. So why do you think we have such a hard time getting a mortality signal with any of these trials? I mean, and none of the HFpEF trials.
So that's a tough question, Ileana. Why do we have such a hard time in seeing signals on mortality? What I believe, and also in Paragon HF, you see that the curves are diverging all the time until the end of the trial. HFpEF is a disease that evolves over years and years and years. And HFrEF sometimes, after myocardial infarction,
Bang, it's there.
you get immediately into HFrEF.
Yeah,
So
yeah.
how can you reverse a disease that has evolved over years and years within, say, 24 months? I think that is that is
You may
not
have
an
something
easy
there.
undertaking,
Right.
and I'm personally convinced that it is more the intermediate term and the longer term follow-up of these patients. Not all are 80 or
Yeah.
and where we might then also detect
The
clear
difference.
signals that the difference on
But it's going to
mortality.
take longer than the actual follow-up.
Absolutely. And here I think we also have to adapt the way we do trials. I mean, we are not following these patients once they are censored or the trial's over. We are not following
Yeah, we
these.
keep using our HFrEF information to set up the HFpEF trials.
Absolutely.
So I have one last question for you. The MRAs,
Yeah.
for the audience, the mineralocorticoid receptor antagonists, were kind of low in this trial. The 20, 24,
Yeah.
something like
yeah.
that. Why? I mean, it's a drug that we've been using. TopCat certainly had very strong signals for spironolactone. Why are we using less?
I think I cannot answer the question in all details, but there is some regional variability. So there are countries which a better uptake of MR antagonist therapy in HFpEF. The US, I think, does a good job here. You even now have, I think, a class 2B recommendation.
Yeah, it's in the guidelines.
At least, to do this. In Europe, we are not yet so far, but we do use it.
You may want to do a subgroup analysis by region and take a look at the patients who were on an MRA, because I find clinically it works very well with the ARB.
Yeah.
The MRA works very well as long as hyperkalemia.
Very true. You're right. And here again, I do use MRAs in my HFpEF patients.
Sure.
Especially when they are hypertensive, and many are under medication and still in the range of 140 something.
And that blood pressure comes right down. Yeah. As long as the potassium's okay.
Absolutely.
And now we can even manage that.
Yeah.
I want to thank you for your time, and I wish you luck. I look forward to other papers.
Okay.
You also have a Kansas City cardiomyopathy questionnaire that didn't change a lot.
Yeah.
And that's very intriguing. Yeah. So I think that every time we do one of these trials, we learn.
We have a trial on that, Parallax, sacubitril valsartan, which looks specifically into quality of life measures.
So we need to continue to learn from these trials. But I want to thank you. I wish you a lot of luck with the trial, and I'm sure we're going to be hearing more.
Thank you very much, Ileana.
This is Ileana Pina signing off. Please join us for all these blogs, and we will have more information coming from the ESC. Have a great day.